Hello. A little apology, first of all. I didn't realise when I wrote the presentation that I was following Tebello. So my presentation includes a little bit telling you about Lesotho, which I feel slightly embarrassed about when I'm sure Tebello could tell you an awful lot better than I could. But I've prepared some slides, so bear with me, I'll show you anyway. I have to say, first of all, that I haven't ever been to Lesotho. I'm here to tell you about some work that we've done remotely over the last couple of years. And when I say we, me in a very small part, but lots of others who've contributed, some of whom are in the room. So I do hope I appropriately acknowledge everybody who's taken part. So I thought I'd start off with a bit of orientation, which is why I was apologising. Tebello, please pick me up if I misrepresent anything while we're talking about it. I've never been to Lesotho, but I've worked with colleagues in Lesotho remotely over the last couple of years during the pandemic. So I've done a little bit of reading about it. Tebello mentioned that it's a relatively small country in southern Africa. You have got a laser pointer here. So this is Lesotho here within South Africa. It's often being compared to Wales because it's a similar sort of size. Lesotho's about 30,000 square kilometres, Wales about 20,000 square kilometres. It's a similar sort of size of population. Lesotho has about 2.1 million, Wales about 3.1 million. It's hilly, and Wales is also hilly. It's a country that's very proud of its heritage and is bilingual, and again, similarities with Wales. But those similarities, that's probably about where it ends, because when I say it's hilly like Wales, Tebello referred to the fact that Lesotho is a very high country. One of my favourite facts about it is that Lesotho is the country in the world which has the highest lowest point of anywhere. So in other words, the lowest point in Lesotho is higher than the lowest point in any other country in the world. So the lowest point in Lesotho is 1,400 metres, and to put that in context for anyone from Wales, Snowdon is about 1,085 metres. And so the lowest point in Lesotho is about 300 metres higher than the highest point in Wales. It's got two mountain ranges in the north and along the eastern border, and a plateau in the middle, which is at about 10,000 feet. So that impacts a little bit on transport and obviously on health of the population. It's a very poor country compared to Wales. The World Bank estimates that the gross national product per individual in Lesotho is about $3,000. In Wales, it's about $37,000, or at least in the UK, it's $37,000. And as a consequence of a lot of these things, then the health of the country is very different from Wales. I put on there that the HIV prevalence is very high. Now, we were talking earlier on in one of the workshops, and we were talking about the fact that there were quite a lot of doctors in the audience, and we ended up apologising that we're doctors. So I apologise if this is a bit of a doctory sort of slide. But when I was learning about the country and the doctors that I was going to be talking to, I found this quite helpful. I suspect there are people in the audience who've looked at graphs like this a lot more than I have, but I find this a very helpful way of just looking at the health of a population. And this chart basically includes all of the deaths in Lesotho in 2019 and divides them into three colours. So infectious disease is in the reddy colour, non-infectious disease in the bluey colour, and trauma in the greeny colour. And the shade of the colour also indicates the change in prevalence over the past 10 years. So, for example, a dark red, as you see from this end of the chart here, indicates a 3% increase in prevalence of that particular cause of death in the preceding 10 years. So you can see very quickly looking at that infectious disease is the most common cause of death in Lesotho. HIV accounts for about 30% of deaths, and the prevalence has been going up in the last 10 years. Tabello referred to changing incidence in non-infectious diseases, and you can see that diabetes, CKD, cervical cancer, breast cancer, liver cancer are all in the darker blue, showing that the incidence is increasing. So that just helped me to get a little bit of a sort of background when I was trying to help people in Lesotho. We talked quite a bit about Byd-eang Cymru. I think one of the things that the work I've been doing over the last couple of years, or the work I've been involved in the last couple of years, has shown me is the value of the Health Links network in Wales and how lots of little organisations, little groups of people can come together for the benefit of others very quickly and very effectively. Byd-eang Cymru is a link between Wales and Lesotho that's existed since about 1985. It's a registered charity. It's based here at the Temple of Peace. And I first came across the work in Lesotho through Paul Myers, who is now the chairman of Byd-eang Cymru. And he introduced me to a group working within Byd-eang Cymru, supporting a group of family medicine trainees in Lesotho. The Family Medicine Speciality Training Programme is the first, and I think I'm right in saying still the only postgraduate medical course in the country. They currently have about 11 doctors in training on the course, and they do a 4-year course to enable them to be family medical practitioners. And it's that group of individuals that I'm talking about this afternoon in terms of the support that we were able to provide under the umbrella of Byd-eang Cymru. Little bit about me. So I was a GP between Chester and Wrexham for about 30 years. I'm a GP trainer. I'm also a GP training programme director for Wales and North Powys, which I still do. So my background is in general practice and particularly general practice education. I put on there that I'm Deputy Lead for Global Placements in HEIW with Gordon Lewis, but unfortunately we haven't got any doctors on placement at the moment, although I know one of the doctors who has been on placement is with us this afternoon. When I finished in general practice, I went off and did the diploma in tropical medicine, which was absolutely brilliant. So I had three months of being a student again, and that's where I got the graph and that sort of interest from. And I had all sorts of ideas about what I was going to do once I'd done that course, and then COVID hit. So I ended up working for the Primary Care Local Assessment Centre, doing their infection control procedures and supporting them, and also working in the local field hospital. And it was while I was in the field hospital in 2019 that I had conversations with Paul about the Family Medicine Speciality Training Programme and how I might help with that. We became aware that the doctors in training on the Family Medicine Speciality Programme in Lesotho were understandably very, very concerned about this wave of COVID that was going around the world and was heading their way. And very concerned for lots of very good reasons to do with their resources, but also the fact that they, as doctors in training, were going to be right at the forefront of this huge wave of illness that was going to happen, and they were really stuck and didn't know what they were going to do. And that's where the sort of teamwork came in, because conversations in Wales let people know that that sort of thing was an issue. And very quickly, a package of support was put together. Now, I mentioned that my part in this is pretty small, but through people in Byd-eang Cymru, through people in Wales and Africa Health Links Network, and through people working in Betsi-Quthing in the psychological services, and part of Betsi-Quthing that supports another project in Lesotho. People got together and there was an application put into Welsh Government. Welsh Government were very supportive and provided money for organisations like this to support others around the globe. And I know Catherine's here this afternoon. Catherine, Isabel and Veronica put together a successful application very quickly for £15,000 to support the trainees on the family medicine programme in Lesotho during the COVID pandemic. And that support was in 4 separate parts. So we had a staff wellbeing and support service. I mentioned that some of the team, so particularly Isabel Hargreaves works with the Psychological Services Department in Betsi-Quthing in North Wales. They had implemented a very successful staff wellbeing and support service in the local area in North Wales, and we were able to get in touch with colleagues who'd provided that service and contract them to provide a similar service for the family medicine trainees in Lesotho. Education and training was something that had been done previously because through Dolan Cymru, through a link with the family medicine programme, people like Paul Myers and others had been out to Lesotho in previous years to deliver training programmes for the family medicine trainees. But we decided that particularly as that was going to be very difficult for them, particularly difficult during COVID, that we would work hard to include that in the programme. And so one of my roles was to help coordinate a program of teaching and training as part of this COVID support package. We employed a local support coordinator who helped with particularly things like making sure people were able to get to appointments and also particularly with the fourth part of the program, which was delivery of equipment, particularly PPE and pulse oximeters and so on. So it made sure that that equipment was received and distributed as appropriate. So the staff wellbeing and support service was run by Doctors Kate Shakespeare and Laura Perry, and they were able to be in contact with the 11 doctors in training in Lesotho. They arranged 35 sessions, which were largely individual support sessions, between September 2020 and February 2021. Of those 35, 19 sessions were attended mainly because of pressure of work, causing people to be unable to attend. But they had individual counselling services, they did some group-based work on compassionate leadership, and hopefully gave tools that the doctors could then take back to their hospitals across the country and help others in the primary care workforce. They produced other materials in terms of some videos and some written material that could also be disseminated throughout the country. And the feedback from the Staff Welfare and Support Service was extremely good. I've said there already that there were colleagues in Wales who've been out working with the doctors in Lesotho on the training programme previously. Clearly, during the pandemic, there was no option to go out there, so we had to move on to remote teaching by Zoom. And we did that in several different ways. So Catherine actually organised a couple of webinars on clinical management of COVID. That was the starter, so that I think was in July 2020. And then I was able to organise a couple of colleagues in surgery in the UK and from Wales to help with delivering some surgical teaching for them. That's another little illustration I think somebody said earlier on about the amazing world that we were suddenly plunged into during the pandemic. I knew a former colleague who was a surgeon in the Wrexham Marlow Hospital, was very interested in international development work and had done teaching in other countries previously, so I sent him an email. He was stranded in France on holiday, unable to return because of the pandemic, but said, yeah, that's fine. So he was able to deliver a talk to the trainees in Lesotho from his holiday cottage in France by Zoom, and it worked, which was amazing. We went on to deliver a 4-day palliative care course in October 2020. That was largely by a Dr. Cliff Jones, who's the RCGP lead for end-of-life care, and I helped and Tabello helped to support him to do that. And again, I think it really opened my eyes to just how effective you could make remote teaching. We were able to get to know the doctors that we were working with reasonably well, and the connection was sufficient to be able to even do things like we did some role play on giving bad news, and it worked. So we could watch them doing the role play and give them feedback, and it was effective. Not quite like the real thing, but it worked. So having done that. The Family Medicine Speciality Training Programme also asked if we could help with supporting some mental health teaching in October 2021, and it was still a bit impractical to go to Lesotho, so we did that remotely. I did some of the teaching, but I was more involved in sort of procuring the education than delivering it. And I was amazed how much help and support I got from people virtually everybody I asked to say, look, can you help with a session on this? So friends from the Liverpool Tropical Medicine course helped out, local consultants helped out, and we put together a teaching program for a week and delivered that again over Zoom. We'd listened to the feedback from the previous one, and there was perhaps a little more that we did try and do to get to know the doctors better. So we spent most of the first morning talking about ourselves, both the doctors in Lesotho and ourselves, so that we got to know each other quite well before we embarked on the course. And I think that helped with the communication. It certainly helped with the empathy, and empathy is obviously very important in communication. We had one particularly amazing talk during that week, which was not one that I'd expected as being a highlight, but a colleague from North Wales who works for Coed Lleol, Small Woods Wales, which is a third sector organisation that promotes mental health work in woodland areas, gave a talk about her work and how that affected and benefited people in North Wales. And the following morning we connected on Zoom, and everybody was absolutely buzzing, and they were all saying, that last talk yesterday was amazing. We were so impressed with the idea of just going out into the natural world and how it might improve our own personal health, mental health. We went and climbed a mountain, and one of the doctors said, I'm from Nigeria and there's no mountains anywhere near my home. I'd never thought of climbing a mountain before, but I did, and it was brilliant. So that was a really successful week. So moving on to now, and Tabelo mentioned that she's visiting, or going home to Lesotho to talk about the hospice in November, and Paul Myers is also going, and they've very kindly invited me to go along as well. So I'm going to go, and we're delivering another week of palliative care teaching in November, but this time it will be face-to-face, and we've got other roles to do, discussing about other links with GP training. So for the first time, after working with colleagues in Lesotho for a couple of years, I'm actually going to go there and see the place. And that's where my dilemma or question comes in that perhaps you could help me with. I think the remote teaching has been much more effective than I ever thought it would be. I think we did find ways of getting to know the trainees and know a little of their situation. As I said, I read about Lesotho, I looked up about Lesotho's medical problems. I like to think we had a little bit of empathy and understanding of their situation. International travel is clearly less time efficient. It's clearly much more costly in terms of finances and environmental costs. But in my other role, with my other hat on as a teacher in the UK, we've also been doing remote teaching using Microsoft Teams with the GP trainees, and we thought that was going okay until we actually got to meet them again, and we realized all that we were missing, people we didn't recognize, people we'd formed opinions of that were completely different, all those discussions that you have outside of the core stuff of talking or telling them about the medical problem that you're discussing that day, we missed out on. And I think we have found more empathy and understanding for the GP trainees since we've been going back to face-to-face teaching, and they've certainly appreciated it an awful lot more than the remote teaching over a video link. So I'm convinced that there are benefits to face-to-face teaching in terms of understanding and empathy with the audience, but how does that weigh up with those costs of international travel? Is it justifiable to go to the other side of the world on an aeroplane to deliver teaching that you could do remotely? Does the empathy and understanding that you have for those people that you're talking to, the benefit of the improved communication face-to-face, does it outweigh the costs of the flights? So I talked to a few people about it and just put up a few comments that I had. How does empathy help in teaching? I think it does. Teaching is all about communication, and in order to be able to communicate, you need to be able to understand and empathize with those you're talking to. So I think empathy is very important in teaching. I guess a more broad comment there, kind of relatively well-off older doctor, this was one of my colleagues, in a reasonably well-resourced healthcare system, empathize with a less well-off doctor working in Lesotho with different circumstances, resources and culture. I don't know, but I'd like to try. And several people have commented that they thought it was actually quite timely now that we are able to travel again. We have had that forced experience of having to use remote communication for the last 2 years. Where does the balance lie? Surely there is going to still be a role for that remote communication, but is it still justifiable to go back to face-to-face teaching when the distances involved are so great? The quote at the bottom I quite like. There's a book about consultations, a very old book now, by a chap called Pendleton and colleagues in 1984, and he quotes a Danish philosopher and theologian from the 19th century, and that's the last stanza of the poem there. The poem basically reinforces the idea that in order to be able to help someone, to be able to communicate with them, you need to be able to understand them. Thank you very much for listening to me. If anybody's got any questions. Are we taking questions now or at the end, Beth? Now. Yeah.
Mine is more a comment, really. We deal with midwives in Sierra Leone and Liberia, and for the last 2 years we've had to have Zoom sessions. It's quite difficult to teach neonatal resuscitation or obstructed labour over Zoom, but we managed it. But for me, the most important thing really was keeping in touch with them, with our midwives over there, which we weren't able to do during Ebola because we didn't have Zoom. But also, I think what we need to factor in is how it changes us as individuals going to the countries, which you miss out on Zoom. So my life has changed. I think it's fair to say that every midwife who's travelled to Africa has come back a better midwife and a different midwife. And the value is priceless. We can't really estimate it. So I think a combination of the two is good, but I think face-to-face is really, really important. Thank you.
Any other questions? There's a gentleman over there.
Thank you very much. Very interesting talk. I worked in St. James's Hospital, Mansignani, in about 2006, 2007, when ARVs were just being rolled out in southern Africa. And my experiences then are sort of embedded in my memory for various reasons. But because such a high proportion of people in Lesotho are on antiretrovirals, I was wondering whether you would like to make any observations on the prevalence of COVID infections in Lesotho in the last year or two. Thank you.
I would have to say that's beyond my experience. I don't know. The only figures that I'm aware of are things that I've found on the internet, which are from a couple of years ago, so not in the last couple of years, no. Okay. Thank you very much.